Hi everyone, good afternoon. I'm Samantha. I'm from the School of Health and Nursing. Today we'll be having our university partners from Edinburgh Napier University talking more about the care of elderly during the COVID-19 period. Just give me some time to just share with you the slides. Okay. So we'll watch a short video and then we'll continue on, yeah? Thank you.
Hi there, welcome to our talk today. My name's Janine Afseth and I'm the program leader for our BSc Nursing in Singapore today. And I have with us Bruce Harper-McDonald, who is one of our program team and the deputy module leader for advancing practice through research, which is one of our modules within it. Bruce is also an advanced nurse practitioner who helps coordinate care in the community and has been actively working during the COVID pandemic in Scotland. So I'm going to talk to Bruce a little bit more about that in a minute. But what I'm first going to do is just outline a little bit of the general situation with what's happened with the COVID pandemic in Scotland. Scotland, unfortunately, was very badly hit with incident cases and deaths since the COVID pandemic started in Scotland. Over the time since we started to get cases and deaths, which was around March time, we've had in total 4,155 cases in which COVID was mentioned as a contributing cause to people's death in Scotland. Of those, not all of them had a positive test. So we had 2,486 confirmed deaths where we had the COVID test, which confirmed that person did have COVID at the time of their death. At the moment, we've had 263,600 tests done in Scotland, and of these, 18,259 have been positive. So from that, you can see that we've had, out of the positive tests, a fairly high death rate compared to certainly what I've understood from the situation in Singapore. However, we're very glad to be coming out of that. We had 8 new cases today, which is July the 1st when we're making this recording, and 1 confirmed death. So we're hoping that we've moved in the right direction. Since I think the 23rd of March, around that date, we've been in a lockdown where people generally at the start were staying home except for exercise or essential work or to get supplies and groceries. And we've had some gradual easing of that where the times people can be out exercising has extended. But also during this time, additional measures such as improved contact tracing in Scotland and the need to wear masks in shops and enclosed public spaces has come into it. So we hope we've moved in the right direction, but within that, one of the unfortunate things that happened is within our older people's population, we had a disproportionate amount of this population which were impacted by the COVID virus, and in fact a very high death rate, and Bruce has a great deal of experience in that, so he's agreed to talk to us a little bit about that today and tell us a little bit more about his experiences and what he's observed during the COVID pandemic in Scotland and what we can learn from that. So Bruce, thank you so much for agreeing to talk to me about this topic. As I mentioned, you are a lecturer and you lecture for us in Singapore and advanced nursing, on our research module there. But can you tell me a little bit more so we understand it fully about the advanced nurse practitioner role in Scotland and what kind of roles and activities you take within that?
Yes, thank you for asking me to take part in this interview today. The role of advanced nurse practitioner is something that's growing quite rapidly across Scotland. My specific role working in advanced practice is coordinating out of hours services. So that's out of hours nursing services, and that's for any care that people require at home. It can range from home ventilation, so we have ventilated patients that are dying with COVID-19 at home, as well as injections, end of life care, to more simple nursing procedures. But it's providing that level of nursing care at home. The reason it's an advanced level is we're autonomous, so we don't work under the direction of a doctor. We provide the service ourselves and are totally independent to that. So my role would be to coordinate the nurses that are delivering care within the community to patients.
Yeah. And can I confirm as well, Bruce, do a lot of these nurses undertake the prescribing of medications and kind of the whole care package within that?
Yes, as part of my role, I would coordinate the shift. So that's all out of our services across the whole of Edinburgh. And as part of that role, you have to have done a postgraduate master's to do that and have that advanced practice certificate. And yes, you would hold a prescribing qualification. So when I'm coordinating, I will have community nurses working for me that don't need the prescribing skills, but myself as the advanced nurse practitioner on duty, I would have that. So I could prescribe for the patients that need during the shift.
Yeah, and that's great. So also to set the context a little bit, could you tell me a little bit more about how older people's care is organised and supported within our health service in Scotland, and kind of the social care aspects as well that I know you might also support?
Yeah, so I suppose care is a bit different in Scotland than how it would traditionally be delivered in Singapore. So what we would often have is patients that are in their own home, so we'll go and see them in their own home and look after them. If they need care at home, they get what they call a social care package, so they get a carer from a company that goes in to provide the personal care. Now, it's not normal in Scotland. I know in Singapore often people have live-in carers that are there 24 hours a day. That's not common practice in Scotland. It'd be very expensive and unaffordable for most people. So if people start needing more care, if they can't cope with somebody coming in a couple of times a day, they move into what we call a care home, where there's 24-hour carers there and a number of patients that stay within those care homes. So it's quite common for myself. As a nurse, we go in and we support the carers if there's nursing needs within the care home. So that can be anything from as simple as looking after the catheter to providing palliative or end-of-life care.
Okay, great, thank you. And I know you, of course, supported this care throughout the pandemic that we still have ongoing. Could you tell me a little bit more about the differences in how this care was delivered during the pandemic, kind of in both settings, in the community and maybe into the care homes as well that you supported?
Yeah, so obviously with the pandemic, the role of what we were doing in the community changed dramatically. Traditionally, I would be based out of a satellite hospital, if you like. So I'd be based within a hospital setting where I'd be based to go out and do my work. For obvious reasons, we were no longer able to do that. It was seen as too risky, me going from a hospital to a community back to hospital. So we were completely isolated, moved into new premises, if you like, so that we were held separately. Initially, the idea was, and again, with a lot of this, and I'm sure Singapore is the same, there's been a lot of lessons learned along the way, so we might have done things differently. But initially, what we did do was we had COVID team and a non-COVID team. The idea being that if a nurse had been in to see somebody with COVID, they would only then go and see people with confirmed or suspected COVID, and then we would have a secondary team that we would call the non-COVID team. So they would go into see patients that didn't have the symptoms of COVID. This was a good initial start and really what we wanted to do. However, as the pandemic unfolded and the numbers increased, we just didn't have enough resource within the service to provide that. And we ended up having to go into people with COVID and without COVID in the same shift, which then had an impact on how we delivered our service, because then we've had to nurse every patient as if they were potential COVID. to protect them from us as well as and vice versa as things changed. And certainly, you know, care at home has stayed much and such the same, to be honest with you, and the incidence of COVID of the patients we look after at home really has remained very low. What we have found, though, is the incidence of COVID in the care homes, sadly, and it has hit a lot of the news in Scotland, spread very, very quickly in the care homes and became a very difficult situation to manage. So traditionally, I could, in an out-of-hours shift, not visit a single care home, to, at the height of the pandemic, spending the whole shift in a care home setting providing palliative care to people with confirmed COVID. So that was a big change. And I think, you know, part of the issue that we faced in the community was, as the pandemic unfolded, a lot of the priority was around intensive care beds and releasing capacity in hospitals, which I'm sure is similar globally and certainly would be in Singapore. The problem with that is that led to a lag in what available resources were put into the community, and unfortunately the lag in that arriving. So for example, one of the lags was around PPE. You know, I remember being on a shift and we didn't have PPE in which to wear the mask and the visor when we were going into the care homes, so we had to make do with what we had. And I think that's a lesson learned at a government level, was that it just meant it was too late.
Yeah, so very, very, very significant impacts really on that population. You know, obviously we had high deaths in some of the care homes and, you know, a lot of tragic consequences, but there possibly were other impacts on some of the older people's health and well-being just as a result of the pandemic going on, or how care was delivered. Could you tell me a little bit more about that, and if you observed any other significant impacts with your nursing support and care of this population?
Yeah, certainly. I mean, obviously we've got the impact of people dying with COVID and providing palliative care in the care homes. And that in itself has been a massive challenge, because our medical colleagues, so doctors, would not visit care homes. They were not allowed to visit care homes. So we were providing all the care to the patients without medical support, if you like, which is challenging in itself. And obviously in care homes, you don't have the ability to ventilate somebody, so it was maximum amounts of morphine, for example, to help with the breathing. So the palliative care aspect was very difficult. Palliative care difficult for the older person as well, as normally you would invite a family member to be with them, or to have somebody. Sadly, a lot of these patients have been dying on their own, because certainly the rule of most of the care homes, and based on the government advice, is no family members to be present or to be visiting the care homes. So that's certainly the COVID population. The problem is, for the wider care home, is all the patients within the care home have had to be isolated within their own rooms. So strictly not allowed to come out their own room. There's no social space, no social activities happening. So this means we've got older people living then in what are quite small rooms. They are en suite, most of them. You know, they do have their own toilet and shower, but they're not seeing anybody. The family are not allowed to come in to see them. They're not allowed out their room. And you can imagine, for an elderly population, that's difficult in itself. They're not seeing their family, they're socially isolated, they're not getting mobility or any type of stimulation. So I think that's difficult for most elderly patients, as it would be for myself or anybody that would be isolated to that level. But what has been specifically difficult and challenging has been for patients that have dementia or a cognitive impairment. So if you don't understand that there's a virus and a pandemic, and that's why you're being held in your room, to that patient living with dementia, it's just a torture. It's like cruel what we're doing.
Yeah. Oh, absolutely, Bruce. I mean, what could be done, or was there anything that you could kind of find that the care home staff or yourselves were able to do to help people maybe suffering from cognitive difficulties or dementia in this very challenging time?
I think, sadly, and being very honest, at the height of the pandemic, we were struggling to deliver palliative care to patients that were dying. So actually, to provide cognitive care or to worry about that, we often didn't have the time to do that initially. Sadly, And unfortunately, as the number of deaths in care homes were significantly high, sadly, as more patients passed away, that did release some of the care staff to have more time because they had less patients within their service, so they could spend more time with them. One thing they did in Scotland, which has been very positive and very welcomed, is our students, our student nurses have been allowed to go into paid temporary employment, which has allowed a significant increase to the workforce. So luckily the care homes got extra resource from that. So they got extra. So these were nursing students not qualified but allowed to go into paid employment as an acting nurse, if you like. So that gave extra staffing for that. I think the biggest reflection is, and it's trying to weigh up, is what's better? Is it better to provide, there was a risk assessment has to be made as if somebody's palliative with dementia, they're at the end stages of their dementia. Is it better to let them walk around the care home and socialise with somebody else that's end stage palliative with dementia? Yes, they might get COVID and that might cause them to pass away. Sadly, is it better that they are put at risk of getting COVID at the end of their life, but means that the end of their life was better than being socially isolated and prolonging what was a life-limited disease anyway? And that's something we've started to have to grapple with, and certainly something we're going to have to think about moving forward, because it's unlikely that COVID will be eradicated completely.
Yeah, I mean, a lot of ethical issues to really think about in the delivery of care that we've probably never had to think about before, really.
No, absolutely.
When you're talking about this, Bruce, the personal impacts, I think I would have felt them, but could you maybe tell me about yourself, or maybe what you observed in some of your colleagues in relation to some of the personal impacts of working in a very pressured and stressful situation like you've described, where there's kind of so many pressures on you for nursing care and also decision making and things like that?
Yeah, I can share some of my feelings and some of what my colleagues have spoke about. It's almost like a roller coaster of emotions, to be honest with you. Certainly when when the pandemic was unfolding and getting to the height of where it was, there was almost a fear. So a lot of the time it was quite scary to go to your work because you didn't know, well, what am I going to face today? What's changed today? What's happening tomorrow? So that was quite odd, in that I feel very confident and competent in my role. So to go from confident and competent to suddenly feeling almost quite nervous and apprehensive about going to your work. At the same time, for a lot of people, when you're locked down, especially from my role as a lecturer, I don't feel I'm able to do very much. So to actually put your uniform on and think you're delivering care is hugely rewarding. So whilst you're apprehensive, it's rewarding to think that you're actually managing to do good. And at the same time, the sort of third feeling that comes through is frustration. So certainly in Scotland, we've been living through a lockdown. There has been cases where people have not followed the lockdown. They've had private parties at home or gatherings outside. And that's very, very frustrating when you know what you're facing and what you're seeing. And I think sometimes a lot of what I was seeing, the public weren't seeing. So when you've seen a group of teenagers sort of having a picnic in the park, it was very upsetting for us as staff seeing that, because we knew what was happening sort of in that environment. And I think the last thing was, whilst it's difficult as a nurse to deliver palliative care anyway, I think what's very, very difficult is when you're not managing to deliver palliative care as you would want to, when you're seeing distressed people being held in their room that don't understand it, that, at its worst, you couldn't get round to see patients quick enough to deliver optimum palliative care. So that in itself is quite difficult in emotion. So it's a trajectory of feelings, if you like, of feeling that you're doing good, frustrated with the wider system, and a bit of distress around what you're seeing.
Yeah. Hugely challenging, I would say. In terms of, where we go from here, one of the thoughts that comes in my mind is, as a program leader for BSc nursing, is what skills and knowledge do you think that is really important that we focus on, or that would help people deliver care in challenging times like this, that would be a benefit?
suppose for me, when you look at what's happened, there's been an awful lot of services that have been nurse-led in Scotland. The traditional medical model has not followed. Nurses have really had to up what they're doing and what they're providing. And certainly when I qualified as a nurse, the Scottish model used to be very similar to the model in Singapore. I had done a diploma of higher education. So I know a lot of the Singapore students are coming on to do their BSc top-up. And I think more than ever, it's important to think about topping up that qualification, because anything that puts you to a higher skill level means it's a higher level of care you can deliver. So certainly I think from an educational perspective, advanced roles will be the future, and they'll continue to advance. And I know in Scotland, we sort of moved from a diploma focus to a degree focus to now actually looking at a master's focus for advanced practice. So, certainly somebody thinking about doing a BSc top-up, I think now more than ever it's really important. I think specifically for me, teaching on the advanced practice through research, I think that's a lovely module to start as a nurse thinking, what can I do? Where do I fit within research? So what if I see a problem? So for example, some of what I've seen during COVID, how can I turn that into nurse research, and how can I lead research to improve care for patients in that group? So more than ever, I think that doing something like a BSc top-up, not only because it's advancing your skill set, so for example the health assessment module that runs on the programmes, that's going to help you assess to a higher level. You're going to learn more about how to lead care for patients at an advanced level, and also thinking about how you can use that experience to inform research.
Yeah. Well, Bruce, I have to say I really appreciate your time and your insight into what's been a really, really challenging time in Scotland. And I think I say from all of Scotland again, also thank you so much for going out to the front line and helping with our healthcare. I think that's all my questions, but is there anything else you'd like to add that I've maybe missed or that might be useful with that?
No, I just want to say thank you. It's been a really good, nice opportunity to talk a little bit about what's been going on in the Scottish context. And hopefully some of the people that are watching I might come across if they come and study the advanced practice through research model. It'd be nice to see them. I always really like working with the Singapore students and sort of learning about the healthcare system in Singapore and how it compares and where we can learn good practice from both sides.
Yeah, great. Well, thank you, Bruce. I would just like to reiterate what you say. I mean, as a program leader and lecturer on 3 of the modules, I find that as well. You're there to teach, but actually we also recognize everyone's experienced practitioners. And I always, find, although we're giving knowledge, we always gain knowledge from our students as well, and from the experience of healthcare in Singapore, which also teaches us things about our healthcare. So.
Absolutely.
Great. Well, thank you very much. If anyone wants to get in contact with Bruce or I further, the staff at MDIS have our contact details, and please don't hesitate to contact us at any time if there's anything you want to ask about. Thank you, and have a good day.
So that was very motivating and enlightening video from our partners at ENU on the care of elderly in the COVID-19 pandemic. And in light of that, I believe that the healthcare revolution for the new normal is what MDIS is bringing in terms of the courses that we're having. We are bringing in 3 new courses: health management, public health, as well as healthcare management on top of our current nursing program that we're having. I believe with the current healthcare system, it's ever changing and ever evolving, as well as adapting to the global issues that we face, such as COVID-19. I believe healthcare professionals have to be easily adapting to all these kind of new normals that we will face as time goes by. So for some of the courses that we have with Edinburgh Napier University, or ENU for short, let me go into why ENU. In 2019, under the International University Rankings as QS stars, they actually ranked 5 stars for teaching quality, internationalization, as well as employability. the Guardian University Guide in 2017 actually compares entry requirements with final degree awards and ranks ENU top in the UK for adding value to their students. So their student population at ENU is about 19,500 students, and this is across all their campuses, not only in Edinburgh, but as well as the overseas programs, and that includes here at MDIS. In terms of employability-wise, for undergraduate students is about 95.1%, and for postgraduate students is 92%, which is fairly high for students who are able to find work or further their education 6 months post-graduation. And ENU really believes in evidence-based learning, and more than half of their research was rated either world-leading or internationally excellent in 2014's Research Excellence Framework. And they really, really believe in building their students for success and supporting them after graduation as well. They've supported more than 350 startup companies, and a 2014 report in Bigger Economics actually named them most successful university in Scotland for graduate enterprises and startups. So at MDIS, we have two courses provided by ENU. One is the Master of Business Administration, Health Management. This is a fully online learning, e-learning course. It's actually designed to deliver accessible and creative as well as flexible education for the potential students coming on board for this program. The curriculum is specifically tailored for the dynamic contemporary global business application of management theories to be applied to the current practice in healthcare. They also have key focus on innovative and creative problem solving, as well as critical thinking and strategic reasoning. I find that that is really key in the healthcare system due to the ever-changing and evolving problems that you may face in the healthcare setting. As for our Bachelor of Science Nursing top-up program, it actually helps develop required critical and inquiring approach when it comes to problem solving, as well as innovation. So it also believes in evidence-based practice as well, to support high-quality, safe, evidence-based and effective care across a dynamic contemporary healthcare environments, as well as collaborative working environments. It also allows nurses to possess the knowledge, skills, and abilities to practice collaboratively across all healthcare community settings, as well as global health. So moving on to the Masters of Business Administration, the e-learning course for health management. The duration is 21 months with online classes. Commencement dates are in January, May, and September next year, 2021. And the entry requirements is approved English language requirements. For the Masters of Health Management, the IELTS is about 6.0 overall, or equivalent. So as mentioned previously, this whole idea of this course is to promote continuous learning, and I believe online courses is the way to go because it allows students to have very accessible learning, not just coming onto the campus. It's also a theory to practice method, and it allows students to make their mark both innovatively and creatively through problem solving and critical thinking, as well as providing them with the skill set for effective and competent management skills. For the Bachelors of Nursing, Bachelors of Science Nursing, sorry, the duration is 24 months. This is a fully part-time course. Commencement dates, we're actually having our ongoing matriculation for September 2020 intake. This intake is actually have been granted a scholarship of $3,000 rebates by ENU itself. And the next upcoming intakes is in January and May next year in 2021. Entry requirements for this course, the students have to be nursing diploma holders with current Singapore Nursing Board practicing certificates, as well as the approved English language requirements, which is IELTS 6.0 overall or equivalent. So as I have mentioned previously as well, it provides the critical thinking and skills, as well as enhancing nurses' knowledge through this course, competence development, as well as enhancing a collaborative environment in the healthcare setting. And it also promotes being patient-centered and a patient advocate for nurses. Moving on, we actually have two new up-and-coming courses. It's from Northumbria University. So Northumbria has been ranked 351 in the World University Rankings by Times Higher Education with an overall score of 4.3 stars, according to student reviews. They are also known to be innovative and entrepreneurial, and they are ranked 4th in the UK for graduate business startups. Why NU? They are also research-rich, business-focused, and a professional university with a global reputation for academic excellence. They work with major global employers such as Nike, IBM, Nissan, and Procter & Gamble. And they also have more than 560 employees and 60 professional bodies that actually sponsor or accredit the university programs. So the available courses that we're bringing in from NU here at MDIS are two courses. It's the Masters of Public Health as well as Masters of Science Healthcare Management. So Masters of Public Health focuses on evidence-based practice to synthesize the contemporary public health theories and policies and practices, along with the evidence-based knowledge to implement public health, implement key policies and practices in the public health areas of health promotion, protection, as well as improvement, and not only in the Singapore setting, but in a global front as well. It allows students to have the knowledge application, taking the theory and bringing it into their current practice, and critical analysis and reflection. So students are really encouraged to challenge their existing knowledge, beliefs, and attitudes, to analyze as well as reflect on how they can better the policies and practices in our current healthcare system. It also helps enhance employability through critical analysis of models and skills required for management and leadership, and system-based thinking for public health and or healthcare-related contexts. This is also focusing a lot on independent learning for students to conceptualize and apply the theoretical perspectives to complex public health practice or policies, to produce a dissertation demonstrating originality in the application and integration of new and existing knowledge. For the Masters of Science Healthcare Management, they also focus on the skills and competency development. So with the current skills that they have, what they intend to do is develop it further to allow the students to sustain change and formulate balanced judgments, both in their own practice and more generally within the healthcare context. Critical awareness and knowledge to develop the comprehensive knowledge and understanding of the healthcare management system, and being able to demonstrate a critical awareness of key issues when it presents itself in their current setting. Innovative approaches as well as policy, practice, and evaluation to develop the sufficient critical analysis skill set and evaluation skills to create new and innovative approaches to practice by critically reflecting on the contemporary healthcare management issues and providing the theories along with their knowledge to help them better effectively manage and lead their team. It also promotes independent thinking to understand and justify their own opinions and recognize the need to challenge one's thinking and the thinking of others throughout the program. So the Masters of Public Health, there's two kinds of courses. One is full-time, which is 12 months, and part-time, which lasts 18 months. The commencement date is tentatively in September 2020, and entry requirements is an undergraduate degree with senior work experience in healthcare practice, or mature candidates of 30 years old and above with 8 years of relevant working experience. Approved English language requirements for the Masters of Public Health, that will be IELTS of 6.5 or equivalent overall. And as mentioned in the previous slide, Masters of Public Health actually concentrate more on problem solving and innovation, continuing advancements, data analysis, and balanced judgments for the policies and procedures in the healthcare system. Masters of Science Healthcare Management, there's two courses as well. Full-time course would be 12 months, while the part-time course is 18 months. commencement date is as well in September this year, 2020, and the entry requirements are similar, which is an undergraduate degree, senior work experience in the healthcare practice, or mature candidates 30 years old and above with at least 8 years of relevant working experience. Their approved English language requirements is also an IELTS of 6.5 overall or equivalent. So if you do have any further queries, you can actually reach our consultants at these numbers, Sinosa and Richie. Their mobile number as well as their email ID is indicated here. If you have any questions for me right now, maybe I can take some questions. If there are no questions, up next, there is a talk on wireless networks by the MDIS School of Technology by our Associate Lecturer, Dr. Lam Kam Ming. And I thank you everyone for your time. Stay safe and take care.